So my name's Becky. To follow up with the question that the doctor asked, like who's doing this work? So the agency that I work for is doing the work. So I work for an agency called FamiliesPlus. It's a nonprofit. I'm going to take this off. Okay, that's better. It's a nonprofit specialty mental health center in Delta, and we have two different arms. One of the arms of FamiliesPlus is that we work with kids who have complex needs, providing wraparound support systems for them in Delta County. The other arm of what we do is integrated care. So I'm here to speak about that piece. Learning objectives for today are that hopefully you all will be able to identify some of the barriers to integrated care. And then you all will become knowledgeable with the 5 A's of integrated care. So a little bit about FamiliesPlus. Like I said, we're based out of Delta. We serve all of Delta County. We have a little office in Delta, but two years ago, our director, whose name is Brenda Holland, wrote a federal grant through the Office of Rural Healthcare Policy, and we were awarded a 3-year, $300,000 grant that started in May of 2015, and it goes through next April 2018. So what that grant includes, it's a consortium of 4 entities. One is FamiliesPlus, the other one is Delta County Memorial Hospital, the third is Stony Mesa Family Practice, and the fourth is Delta Health and Wellness. So with the hospital, we have 2 behavior therapists housed at Delta Family Practice, and one of those therapists is here, Betsy Nordstrom is here. And then I work in 3 other clinics, so we're actually hopping around a lot in the county. Our full FTEs is 1.5, so we don't have that many hours in clinics. So we have limited time to provide a lot of services. So this is who we are. Brenda Holland is a psychologist. She's the one who wrote the federal grant. She's also the director of FamiliesPlus. She's over on your left. Susan Siminer is an LPC. She works in the Delta Family Practice. And then Betsy Nordstrom also works in the Delta Family Practice. The way they work is they split a week. So one of them works Monday through half of Wednesday in the office, and then the other one splits the second half of Wednesday through Friday. My scenario is a little bit different. I travel around to 4 different offices in the county. So I work in Hotchkiss, and then I work in 3 different offices in Delta. So it's busy. I said a little bit about how that works. I am in set hours at the Stony Mesa Clinic. I'm there on Mondays afternoons. I'm at Delta Health and Wellness on Tuesday afternoons. I kind of float where I'm needed on Monday and Tuesday mornings, so I can go and be available at other offices. And one of the reasons is that my degree is I'm a licensed clinical social worker, and only LCSWs and psychologists can see Medicare patients. So this is something to pay attention to if you are considering starting this. If you want co-located or integrated care and you're going to see Medicare patients and you only have LPCs, you will not be able to bill for those services. So there's been lots of awarenesses for providers in setting this up, and we've had lots of challenges and barriers along the way. So one of the reasons that I'm kind of like the mobile therapist is I can see Medicare patients in these different offices. So I'm going to blast through these slides pretty quickly, and then I'm going to open it up to questions because I'm interested to hear what people want to know if they're starting this. So, and if not, it'll just be a short presentation. So we've had so many challenges when at that last slide when they talked about if you are going to start it and there's all these great resources, that would have been so fantastic to have when we started. Those resources might have been there, but we didn't know about them, or we weren't privy to them, or they might not have been applicable, because when you are in the rural frontier, it is totally different than when you're on the Front Range, as most of us in this room know. Some of the challenges I feel that have come from this integrated program is that I don't feel like we are that integrated. So when the first presenter spoke and she had that grid of the different levels of integration, I feel like we're at a 3.5 to a 4. And part of that has to do with I'm not in one practice all the time. You know, I'm co-located. And so someone from the office staff will say, hey, we have this patient, can you meet with them? And I'm like, yeah, they Medicare? And it's like, sometimes I don't even know why I'm meeting with someone. I just show up and they're like, do you have Medicare? Okay, here we go. So there's a lot of the continuity has not been there in some of our efforts of what we're doing. However, I'm able to see people. And 2 years ago, that wasn't so in our county. One of the things that I feel like behavioral health specialists get pigeonholed into is providing mental health treatment, and that's not the role. The role is to do consultations, to work with providers, to be involved with warm handoffs, to do quick behavioral interventions. And what happens with our program, I feel, is because we are really limited by the amount of treatment providers where we live, we end up doing a lot of traditional therapy. And if you're starting your program, that's something to pay attention to, because behavioral specialists and integrated care isn't ongoing treatment. It's not, I mean, sleep hygiene is not the same thing as treating long-term trauma. And so we will walk into an office and I think I'm doing sleep hygiene and I'm working with someone who has like full-blown PTSD and I'm like, hang on. So that's really something that I think that is something to be aware of, is if you're setting this up where you live, who are your other treatment providers? You know, we're able to use the Center for Mental Health, which we do a lot, but other than the center, that's really the only game in town. And they're tapped out and maxed out just like we are. So since we're there, we end up doing a lot of that. So that's a consideration. Another consideration is billing. And because FamiliesPlus has this grant, we have to pay for our time, we being the therapists. So we have to bill for the hours we are seeing patients. So when we see patients, we are then billing for that time. The clinic is not billing for that time. So that's a timely process. I mean, that takes its own paperwork and its own follow-up, in addition to following up with the providers, following up with documentation, and doing whatever other continuity of care needs to happen. The EMR, someone talked about the EMR. So on a given week, I use 4 different EMRs. And in a given day, I use 3. I use Epic through St. Mary's. I use 2 different Athenas. I use Practice Fusion, which is a fun little ditty. Does anyone use Practice Fusion? I like Practice Fusion. And Epitomax, which is for our behavioral health charting. So navigating this in my day takes an extraordinary amount of time. So when you're looking at how to make this easy, one EMR is the best, if that's what you can get away with. Some of the other things that came up for us initially when we started is that we had a lot of just, I don't even want to call it growing pains, but just figuring out how to document in an EMR what's appropriate to put in a medical note. You know, an entire psychotherapy mental status evaluation is not appropriate to put in in a provider note and in a care plan. And so we had a lot of growing pains along the way. And at some point, we were even not able to access the EMR. And so you want to talk about challenging, is when your therapist can't access the EMR, it's really hard to talk with the providers. So we're like, okay, how do we, so we would be calling our providers and saying, hey, I met with Joe Smith, blah, 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 blah. But we got that worked out. And essentially, it was great. I mean, the good thing about the lessons learned is it's made it more streamlined. It's held our feet to the fire, to really help us look at what's accurate documentation for this scope. It doesn't need to be all these other things. But again, that took several months. And so for several months, we're not able to communicate with the providers about patients that we're mutually seeing. So that's a consideration. We did come up with a note that this looks like a lot. This is just what we use for our initial assessment. And not all of that always goes into the note that will go into the EMR, but that's what we came up with. And that took 3 months to come up with that little short integrated care note. And these are all, you can steal, everyone can steal anything. I'm not wed to any of these slides. They're not copyrighted. So I want to talk a little bit about my role at St. Mary's, because my role at St. Mary's, I work in an HIV clinic at St. Mary's Family Residency. So it's a residency. We bring in a lot of nursing students. We have residents, so we're always having new people come in. The whole culture is teaching. And I work with a doctor who has been a proponent of integrated care forever. So our clinic has been integrated for 16 years. So when I go to that clinic, it's like a well-oiled machine. It's beautiful. I don't have to think about what I'm doing. I'm using one EMR. I know the provider well. It's easy. And it's also the expectation of the patients is that they will see me. I am part of the whole medical system. I'm part of their health care. And so it's an opt-out. Like if someone comes in and they say, I don't want to see mental health today, I'm like, okay, I'm not going to see them. But it's presented when they come in for their intake that these are the services you'll receive here in this clinic, and that behavioral health is part of that. So what's been really eye-opening for me about starting this grant with FamiliesPlus is some days this is what it feels like. When I'm at my St. Mary's job, I feel like I'm in a Tesla. And it's like, man, this thing's humming along. I'm doing co-visits with the doctor. Nurses are drawing labs while I'm meeting with the patients. I get kicked out of the clinic. We go somewhere else. It hums along. And then some days when I'm at FamiliesPlus, I can't even find my horse. Like, I don't know where I'm going. So here are some things for consideration, which I probably have already mentioned. Pay attention to the licensure of your therapists. So again, if you want to bill for Medicare, you need to have licensed clinical social workers and or psychologists. That becomes a really big barrier. Medicaid, that's a huge one. So in Delta County, FamiliesPlus is able to bill for Medicaid, which is just a glorious thing, which means that I, as a behavioral therapist, can bill for Medicaid patients as well as the Center for Mental Health, and that's the only game in town for Delta to be able to do that. So we're really lucky. Other considerations, and this has to do with the level of buy-in, both from the patient and from the provider. And we talked about this a little bit, and Alex asked the question about, how do you introduce your behavior therapist to the patient? Because that can be a deal breaker from the get-go. If I am introduced as a social worker, someone's first thought is, you're going to take my kid and I don't need food stamps, and they're immediately, there's no engagement. But if I'm introduced as, this is a colleague of mine, they're on our behavioral health team, they're here to talk with you about your sleeping and your exercise, and she can get you hooked up, or get you a schedule for AA meetings, blah, 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 whatever. Just as long as the words mental health aren't introduced, there is already an increased level of buy-in from the patients. And I like to think about what's the level of the buy-in from the provider. So here's what I've learned in my time of doing integrated care, is that it's really easy with difficult patients for the behavioral health specialist to become the babysitter. So with the difficult patients. So one of the things that I do when I'm working with providers is assessing the buy-in of me working with the patient. So that looks like this. So, because what happens a lot is that as a behavioral specialist, sometimes I feel like this is what I'm doing. Like I am totally saving the provider from this patient who is grumpy, or they don't want to deal with them because it's at the end of the day, or they have acting out kids in the room, or whatever. But that's really not the goal of the behavior therapist. So the 5 A's, and these are important steps to any intervention. And so I put this in my brain when I'm talking with the providers. I'm thinking to myself, from the provider, what's the presenting concern? Is it opioid use? Is it sleep? Is it depression? What is it? And then get input from the provider, like what is it that you're wanting me to do here? Because I tell you what, I have gone on goose chases that were completely different than what I thought the doctor wanted me to do. And there goes a waste of a session. And then assess. So again, the advise and assess, I think for me with the provider kind of go hand in hand. Advise, provider, advise me what you want me to do. What situation am I going into? What am I assessing here? How do you want me to assist that? Is this a co-visit? Is this a consult? Is this a warm handoff? Is this someone I'm going to call at the end of the day? What's my role in this? And then with the provider, be a part of the plan, because especially in the integrated care model that we have often, I may have a provider do a warm handoff with me, and then I don't see the provider again. And so I have to make sure that there's a follow-up plan, and it's often me making that happen because the provider's in another room working with someone else, and I've got my bag, and I'm driving to another town to meet with someone else. So that's from the provider standpoint. From the patient standpoint, it's pretty straightforward. What's the presenting concern? Just to make sure that I'm on the same page with the patient. Advise, just get advisement from the patient about their understanding of why I'm there, again. Assess what's going on with the patient and assist what I can do to help them, and then arrange and come up with a plan. And in in some practices there are continuity of care planners, there's health educators, there's different staff who can help do the case management follow-up piece. That's not true everywhere. So if you're building this model, it's important to know who's going to do the follow-up. Because if it's the behavioral health provider that's going to do the follow-up, then that's going to take more time away from seeing other patients in this whole integrated care model. So I wanted to talk about successes real quickly. We've had a lot. So we have been able to increase collaboration throughout Delta County with our consortium partners, which has been great. We're in the process of doing, we have had one meeting with so many agencies in Delta County just to have collaboration about behavioral health care in Delta County. And what we want it to look like, what are the driving forces, what are our concerns. And so we did that in March. And then at the end of July, we're going to have a meeting, a 4-hour kind of powwow session with these entities and agencies to see where we're going. So we're all hopefully involved in the conversation and we're doing the same thing and we're not all siloed. So that's been a tremendous success for Delta County. We've been able to identify the needs in our county about behavioral health needs. You know, we have one of the things that we have very little of in our county is detox. That's a huge issue for us. There's just really nowhere to send people. So we end up sending them to Montrose or to Grand Junction. One of our successes is that we have, I feel like, good systematic use of screening tools. The PHQ, the PHQ-9, PSC-17 for kids. I use the GAD. I'm a big fan of the GAD-7. And I also like the ACE study, but I do that in later appointments if it's appropriate. So we just finished up our annual report for our federal grant, and we found that 9% of the individuals in Delta County had received either a PHQ-9 or a PSC-17. So it was about 2,700 people, which is a lot. And that number was 0 in the beginning of 2015. So that's really, that feels like we're doing something. You know, I don't have the stats about 6 months later, what was their PHQ-9 score, and did that show improvement and all those things. But just the fact that we started with nothing and 2,700 people had assessment measurements, I'm really pleased with that. Goals of integrated care, these are just things to think about. How to increase access for patients to integrated care. Is it to assist providers with behavioral health care? How will you implement this? Are you going to have a co-located versus an integrated program? And it's a continuum all along, as we've heard today. What is the access to providers like for the behavioral therapists? So are you in the office? Are you seeing patients all afternoon? If you're seeing patients all afternoon, the provider isn't going to be able to come grab you and say, hey, I need you to do the consult with this person who has their PHQ is a 23 and they're suicidal. So what does that look like? Do you have a care coordinator? What kind of screening tools will you use? How are you going to fund your program? How will you sustain your program? And finally, how are you going to know if you're successful? You know, integrated care is new enough that we know that it's successful, but we don't quite know how and why. So stay tuned for that.